Hello, this is the recorded lecture for Information Technology for Health Professionals for Chapter 11. In Chapter 11, we're going to look for information technology as it applies to the rehabilitative therapies, like computerized medical devices, assistive technology, and prosthetic devices. We're going to look at how technology is involved and has improved, those devices over the last few years. Computerized medical instruments, for instance, medical instruments containing microprocessors, computers in their own right, the computerized drug delivery systems, which automate drug delivery, both in delivery of pills, if you will, medications to patients, as well as in IV drips. And that includes the insulin pumps with a chip that gives the user some control. PCP, or there's our pumps, if you will, that, for instance, after a patient is post-surgical, that they can give themselves up to a point pain medication, and they can sort of manage their own pain. And they find that patients who do that are less likely or use less pain medication than patients who don't have that control. We even have medical instruments, which are devices for computer testing, which are worn like a watch on patients and takes fluid to the skin using electric currents, electrodes which measure the glucose. So no longer using needles, that needle stick effect. If you don't think this is an improvement, you have to think about dealing with childhood diabetes, which is a real problem getting blood tests because children don't really like to have their fingers stuck. And using these computerized testers, like watches, if you will, look like a watch with it, there's no repeated finger sticks, really makes them more compliant to the treatment and have better control. You can have physiological monitoring systems that analyze the blood, if you will, that are computerized. Arrhythmia monitors, which monitor the heart rates. We implant these now. If we have somebody who has a recurrent dysrhythmia where they need a minor shock to sort of reboot them, we can plant those in people's hearts now, and it will automatically sort of give them a mini shock and put the heart back online. So we don't have to have them go through the rest, be taken to the ER, that kind of thing. They have pulmonary monitors which measure blood flow to the heart and respiratory rate. So we have these computerized monitors which give us much more information, much more real-time information, much more easily accessible information when it comes to patients. This is looking at an electrocardiogram, which records the cardiac activity of the heart. And this is working on an EKG machine. Now what's nice is this can all be wireless. Now we have wireless mechanisms where we can have those on a patient, and they can go around their daily work, and we still monitor them over that given time. We look at in 2011, researchers at Massachusetts General Hospital developed a portable device, cost about $200, that can be linked to a smartphone that can analyze tissue and predict whether a tumor was malignant or apt to spread. And then the findings are displayed on the smartphone. That's the kind of things we have now where patients are more participative in their own care, number one. And number two is we have more real-time access to treatment. The delays become less and less. In 2011, although the technology has not yet undergone clinical testing, in the early tests and predictions were pretty darn accurate. So we're starting to see some improvement there. Devices for detecting cancer at various stages of development. We have breath nanosensors, which can identify patients with cancer in the respiratory system, as well as distinguish among patients with lung, breast, bowel, or prostate cancers. So we're starting to see improvements that are using these other technologies. We can even see if patients have H. pylori that cause ulcers in the stomach through a breath analyzer now. We have to do that. We used to have to do a bronchoscopy and take a tissue sample, or we'd have to swallow a capsule that they would take a biopsy, that we'd pull that capsule back up. I mean, it was pretty invasive. This is a lot easier on patients. We have fetal monitors that measure heart rates of the fetus, which we've had for a long, long time, but those can now be wireless and Bluetooth, if you will. So neonatal monitors measure that infant heart rate and breathing rates, so we now know, if you will, how they're doing. They can be connected to telemedicine sort of thing, which allows the nurse at a station to monitor the heart rates and the breathing rates of all the neonatal patients in their unit. We have computerized devices which are most likely to be found in like emergency rooms, operating rooms, critical care units, and intensive care units. So they are networked, if you will, so they can be monitored, so we have better access and better control of patient care. Some computerized devices in optometry, ophthalmology, that's working on the eyes. We have Optomat, panoramic 2000 or 200, excuse me, which gives us an examination of the retina. So we can do a computerized examination of the retina looking for subtle differences which we may or may not see with just the naked eye. We have biomicroscopes which help to diagnose cataracts now. Tonometers which measure eye pressure. We used to use these mechanisms where we would anesthetize the eye and put the patient on their back and set these things on the cornea to look for eye pressure or look for glaucoma. Nowadays, for a long time, we've used what are called NCTs, non-contact tonometry, which we blow a little puff of air in their eyes, and that little puff of air would give us would tell us what the interocular pressure would be. That's even moved to the next level where we don't even puff the air anymore, where the machine will be fixed on the cornea and be able to tell what the pressure is interocularly. We also have corneal topography, which maps the cornea, if you will, to determine any irregularities in the cornea. This is a computerized eye exam, if you will. We're going to look into the eye, and then the computer will also review it to determine if we'll maybe see subtleties that the physician may or may not see. Computerized devices in optometry and ophthalmology include the Heidelberg retinal tomograph scans in the retina, which gives us scans and computerized analysis. GDX axis measures, which accesses the retinal nerve fiber and determines whether it's working well or not. Tracy Visual Function Analyzer, which measures how the eye focuses light. All these are available now, which give us much more in-depth analysis of what's going on. We also have electronic glasses. These are smart glasses that are attached to a small computer, and the computer can recognize both people and objects by looking them up in the database. So this is just another mechanism, these smart glasses, which can be helpful. And think about this. Think about this for a blind person. So they can know what's going on around them with these smart glasses even though they're not seeing. Retinal implants are something new. In 2010, retinal implant at HE of Germany announced that its first clinical trial of a computerized retinal chip improved the eyesight of 11 patients to the point where you're able to recognize objects and read at a basic level at normal read distance in irregular light conditions. So retinal implants are now becoming available to sort of replicate the light sensors, if you will, the light receptors we have in our cornea, or excuse me, in our retina. These retinal implants, the device is a 3 by 3 millimeter microelectric chip. It's about 0.1 millimeter thick. It's implanted under the retina, and it stimulates the interretinal nerve cells to generate vision. So it's pretty cool when you think about it. We're helping patients who would not see otherwise electronically. We have other retinal implants. Another approach to the retinal implant is to what's called an epiretinal implant placed under the conjunctiva, which directly stimulates the ganglia using signals sent from a camera and a power sent from an external transmitter. Both are mounted on a pair of glasses, and this approach is being tested in Europe, has been very successful. So we're starting to see other mechanisms to allow people to see and bypass their handicap. In the case of macular degeneration, where we start to see the eyes start to the vision start to go and the patient become blind, the Vision Care Technologies has developed a tiny telescope. It's been implanted into one of the patient's eyes in the inpatient procedure, which may allow them to continue to have vision of some level where they wouldn't have it before. The IMT implantable miniature telescope renders enlarged central vision over a wide area of the retina to improve central vision, while the non-operated eye provides peripheral vision for mobility and orientation. So we're starting to see methodologies using these electronic implants, these prosthetic devices, to be able to implant that process. Here's that Empower electronic glasses, which are being charged, if you will. They have an auto charger, and you can see that it gives the patient a vision that they may not have before based on the implants. Now, Americans with Disabilities Act of 1990 requires reasonable accommodation to allow physically challenged people to work. And on July 26, 2010, that was the 20th anniversary of ADA, President Obama signed an executive order designed to establish the federal government as a model employer of individuals with disabilities. And he did that by increasing recruitment and training of people living with disabilities. That's a big step, because though the ADA made accommodations, it had no requirements, and it did not require the federal government to participate in some ways. It also changes the Department of Justice regulation implementing the ADA will affect accessibility of recreational facilities and public facilities, sale of tickets for accessible seating, and allowing wheelchairs and scooters in all pedestrian areas, among other things. So there's going to be greater ability of people that aren't able to walk, and it will have greater access, if you will, to those facilities. We also have other assistive devices. We have speech recognition devices, speech synthesizers. Speech recognition may be a way to understand what other people are saying for their hearing issues. Speech synthesizers, if somebody's had something that happened to their larynx, they can produce speech, if you will, through the synthesizers. We can have alternative mice, which are a head mouse or a puff straw, which we use a mouse on a computer. We have Braille keyboards now, so a person can type Braille, a blind person can type Braille to other people and can be read by them. And we have line of sight input. So we're starting to see some really important improvements in these things. We also have assistive devices. We have iBot wheelchairs. We have tongue-driven wheelchairs. It's the same. Tongue device can issue computer commands when somebody has some level of handicap. We have smart clothing, which helps a person in multiple ways depending on what we're talking about. We can help people communicate with these augmented communication devices. They're covered by Medicare, and they're using a computer to speak for you. Experimental work on neural implants to allow people to use brain waves to communicate via computer. So what this means, if you start to look at this in the sci-fi sort of way, is that we can start to utilize computers based on our thought process. We can literally access computers without having to touch them or be around them. We can access them through our neural network. Pretty interesting, isn't it? Electronic aids to daily living, which are called EDLs, that's a use of speech recognition or a single switch to control appliances in a home environment, helps to physically challenge people to live very independently. There are other prosthetic devices also. The myoelectric prosthetic limbs with microprocessors that respond to electrical signals from the residual limb. So in other words, we can cause the other arm or leg, if you will, to work based on stimulation from the other arm. The C leg, which is a computerized lower leg, which adjusts to change in pace. It says by 2011, of course, when the book was written, more than 30,000 people have access and are using the C leg. It can now be set by a user for a particular activity, such as even bicycle riding. So if you're missing the lower limb on one leg, you can still have access to ride a bicycle based on computerization of that. E-Legs exoskeleton is a bionic device that helps paraplegics, people who have no control of their legs, be able to walk. It's wearable and artificially intelligent, weighs about 45 pounds, and can be worn over the clothes and shoes. It takes 1 or 2 minutes to put on or take off after some practice. So it's a way that it's an exoskeleton. The skeleton's on the outside, so a person can sort of will their walking pace, if you will, walking pace as they go along. E-Legs exoskeleton is a bionic device that helps paraplegics walk. Like I said, it allows a more natural human gait than other devices and allows the person wearing it to walk at least 2 miles per hour. Now it's powered by batteries, so it has limitations, but it has a real-time computer which draws on sensors and input devices to orchestrate every aspect of a single stride. And this battery operation is being, solar power is being looked at, and there's a new wireless power system that some telephones are utilizing that they think can be integrated into these systems. So basically, they would not have to be charged ever. Now, research is being done on giving prosthetic limbs a sense of touch. So the transference of nerves from the hands to the biceps. So these cyber nerves are created, which form a revolutionary material called PDOT that conducts electrical like wire, in which can be encouraged the growth of new cells. So we can help to regenerate, if you will, nerves and some of the prosthetic parts of the prosthetic limbs, if you will, through this process. Pretty interesting when you think about it. Regrowing our loss of regrowing organs. The computers help them design and manufacture prosthetic limbs, and they are now many prosthetic devices are now specifically coded to the person that's using them. This is computers use design and manufacture lifelike limbs, and they've gone a lot farther than the wooden limbs and the straight plastic limbs we used to use. Another prosthetic device is BrainGate, the neural interface system. And this system involves implanting a chip in the brain that converts brain cell impulses to computer signals. Now think about this. It takes brain cell impulses and changes it to computer signals. It includes a sensor that records brainwaves and interprets them, and it can read brainwave impulses using implanted wires and translate them into computerized commands. Computers that are implanted into prosthetic legs or exoskeletons or whatever, so that it's the brain that's directing the event. Pretty darn cool when you think about it. The BrainGate neural interface system uses BrainGate, which is a man with paralysis of all four limbs, could directly control objects around him or her using only his thoughts. Now think about that. That's almost the substance of science fiction. And BrainGate can be used to control a computer cursor and to control artificial limbs. Think about that. A person that was totally had total loss of all control, paralysis of all their limbs, and basically that's all they could do, could now control the world around them. The retinal implants, we see the prosthetic devices. We have retinal implants to help people see, digital hearing aid to help people hear. We have cochlear implants, which help people hear that never heard before. We have developed bionic ears through MIT. We've developed smart implants using nanotubes to release medications. We have AccuGlove. All these things are prosthetic devices which have helped the people who did not have access to movement to learn to be able to move and to utilize their surroundings. Now, we'll look at what's called FES technology, or CFES, which delivers a low-level electrical stimulation like in pacemakers we talked about before. That's low-level electrical stimulation for the heart. You can have an implantable cardioverter, like I talked about before, defibrillator, and it monitors the heart rate, and it gives them a little jolt. It's internally planted when electricity is needed, which really helps people who have very debilitating chronic dysrhythmias. It helps to reset them on a regular basis, and it's a pretty interesting phenomenon. There's a couple of kind of side effects. One is that if you happen to be holding their hand when it goes off, you get a little charge yourself, which is not terrible. And the second thing is that it will carry over sometimes to if you're using battery operated devices or whatever, it can actually knock them out because you have this charge going on. Now they've improved that to some degree, but we're still seeing some effect there. These also have breathing pacemakers, which control breathing by sending electrical impulses to the phrenic nerve, and it's the phrenic nerve which stimulates the diaphragm to breathe. So we can start to see this effect. So patients who have maybe paralysis of the diaphragm can then be set up with this electrical stimulus and this electrical apparatus, prosthetic device, to manage their breathing. We also have what's called RENA chip, a rehabilitation nanochip, which can analyze the brain's activity to deliver stimulation only when it's needed. It involves connecting a chip to tiny electrodes to provide precisely controlled stimulation to diseased areas. They've started to use this in treatment of epilepsy, of seizure disorders, and we're starting to see that even cross over. It's also used to improve paralyzed people's ability to even grasp, if you will, or hold on to things. It's really improved their ability and their interaction in the real world. We have pacemakers for the brain, which can reduce those seizures, like I talked about, in people with epilepsy, and help control tremors in Parkinson's. If you know who Michael J. Fox is, he's the actor who has Parkinson's, and his foundation, the Michael J. Fox Foundation, has collected billions of dollars to improve Parkinson's disease treatment, and this is one of the things they've helped to author, if you will. You have electrical stimulation, which can strengthen paralyzed muscles, so this FES technology is really something. You have neuromuscular stimulation, which can restore movement to some paralyzed limbs. We have Parastep, which is covered by Medicare. So this mechanism, if somebody's been paralyzed for a period of time or is in a coma for a period of time, we can use these neuromuscular stimulations to sort of bring them back and develop use of those limbs. Now, neuromodulation is a field that helps treat disorders of the central nervous system and other conditions such as Parkinson's disease, obsessive compulsive disorder, pain disorder, chronic nausea, urinary control, and benign prostatic disease. All of these can be managed in some manner through this neurostimulation of the central nervous system process, and so it's pretty interesting. The risk posed by implants is the body can reject them. Implants are made up of materials that the body could make antibodies against them. They have a greater chance of infection, obviously, because we have to insert them in the body. So that's one of the cases, and it doesn't have as much as we might think. And the third thing is blood clots. If we insert something in, we may create turbulence in the cardiovascular system, and turbulence translates to blood clots. If that gets in the brain, that's a stroke. If it gets in the heart, that's a heart attack or myocardial infarction. If it gets in the lung, that's a pulmonary emboli. So those things can happen based on those risks. This is looking at a cochlear implant. That implant is inserted, if you will, and it creates a pseudo eardrum, and that takes the information in and sends it directly through the acoustic nerve to the brain, so the brain is able to hear have it through the hearing apparatus, because perhaps the middle ear or the ear is not functional. Other computer rehabilitative therapies include Helen, which is Help Neuropsychology, contains diagnostic analysis, helps track of tests and tasks performed by a stroke patient. So we can start to manage or specialize treatment and care of stroke patients. We have Motion Monitor, which gives physical therapists measure of a joint motion as it's being used in the patient. So those things are giving us much more information. The vision replacement therapy retrains the brain of a stroke victim who have lost their eyesight, and create or train the brain to start to see in some other part of the brain. I guess you'd say that, to use other parts of the brain to utilize vision. We have computers used experimentally in brain injury and stroke rehabilitation. This area of medicine has not been maximized or fully exploited at this point. We have Para, which is a therapeutic robot developed in Japan, and it's used in patients with dementia to reduce stress. It looks and feels like a little furry seal, and through the use of sensors, it can be light and they can feel being touched or slapped or held, and it really helps patients sort of develop a calmer sort of behavior. Para is a therapeutic robot developed in Japan. It can remember what action produced stroking or slapping, and changes its behavior accordingly. It can be used in locations where real animals can't be used to reduce stress in these patients. So we looked at some of the ways that computers and rehabilitative therapies can be applied in our new technology in this chapter. It's pretty exciting stuff, and it just seems that as soon as you talk about something that seems regular, it goes into what you might think the substance of science fiction. We're doing things now that 10 years ago would be unheard of. Taking a paraplegic who can't walk, putting them in an exoskeleton, and having their brain direct where they want to go. That's pretty exciting stuff. Now, it's not without expense, of course, but it's pretty exciting stuff to give people access to things they might not have accessed before, so they can re-enter society and not be exiled or ostracized or because of their disability. Thank you very much.